how and where people get care, how quickly they get care. Secondary care providers who have worked with primary care colleagues to make a difference. We've seen that specific initiatives and bills being done so that primary care access could be quicker. But never, never in the whole country have we seen access take the shape of the scale we will talk about today, which breaks the barriers between partners, which makes it null and void to talk about local authorities, mental health trusts, acute trusts, community trusts, GP partners, where GP leaders, primary care leaders, have taken the bastion of changing those boundaries so that our communities could get access on a scale not seen before in this country. The phenomenal part is that it is led by the local GPs. And this even scales I have seen only in other countries, never in the UK. Now, our guest today, Dr. Jagan John, is a very dear friend of mine. He's one of these larger than life figures. He is very inspiring in so many ways because in addition to being a jobbing GP, he is an associate medical director of the local mental health acute trust. He is the primary care board member of the ICB Northeast London. He is the director of personalization for NHS London. He's the former chair of Barking and Dagenham CCG. He was the NEL CCG chair. It's one of those CVs that you get breathless talking about. So probably just easier to say, Dr. Jagan John, wow, that GP is the one on our guest. And it is my absolute joy and privilege to be able to have him today as our guest to share with us his experience of transforming access in primary care by breaking down conventional boundaries that have existed between organizations. But just before I do, a reminder, colleagues, we have almost 350 people on the webinar today on multiple platforms. So please use your Q&A button on the Zoom platform to post questions. I will be picking out the themes from those questions you post and presenting them to Dr. John after he's had some time to share his thoughts on what he has done and share his story. Also, many of you have emailed your questions in advance, which was a feature we had given people access to. I will pick those questions up also, so please don't worry. So, without further ado, let me take this moment to invite Dr. John. Jagan, what a pleasure having you over. Shall I hand over to you so you can share your thoughts on what you've led on?
Thank you, Mohit. And what a grand entrance you've given me. My head is very swollen at the moment after hearing that. I mean, seriously, I need you to speak to me every week and I feel a lot better. But thank you very much. And thank you for the invite. And thank you, colleagues, for listening to some work that we've been doing locally in Barking, Dagenham. And this is my journey, my view, and a real collaborative journey between partners, very much responding to a very local need. So it's been a fantastic journey. I'm part of a PCN and one of the co-leads and working with another fantastic colleague, Dr. Nadia Saeed, who works with me as a health inequality lead, but working with Thames Life, which is a community development trust, a kind of voluntary sector group, NELFT, the Barking, Dagenham, BHRUT, our local hospital, and of course with support from our local GP Federation, who supports the kind of health inequalities work for all our PCNs. So next slide. So my journey was really this. I'm a jobbing GP, and I'm senior partner of a practice of a practice that roughly around 25,000 patients, with all different types of staff and different methods of booking appointments. And the thing that I see, Mohit, is really something about the fact that we are dealing with a very deprived population. My population in my practice is very young, very deprived, probably the lowest cohorts when it comes to, deprivation. And the biggest issue that I've always had is actually, are we really catering for the issue? Is the medical need masking something more fundamental? And that made me reflect on kind of Maslow's hierarchy of need, where patients are really, they're not going to listen to the compliance of treatment or dealing with a long-term condition, or even acknowledge they've got a long-term condition if we're not dealing with the main issues in their lives, which is, the physiological, the food, the water, the housing, poverty, feeling safe, having financial support, having a network of friends, and loneliness. And how many GPs among us have are really picking up issues that actually underlying is something to do with loneliness going forward. And then the other thing is, we are trusted colleagues. One of the things we do know, except hairdressers, we are one of the most trusted people in the community. And how do we pick the trust and go even further to get the trust? I mean, there's been a lot of negative press about general practitioners, and Mohit described really the fantastic work that all our colleagues are doing across the country in terms of trying to see and these patients. But how do we develop the trust even further? That was my big issue going forward in my journey. The next slide. So no surprises. Everyone is saying the same thing that us as GPs or community people have been always talking about. Access needs to be improved. We need a neighbourhood team. We shouldn't be reactive as an NHS. We've got to look at prevention. We've got to create capacity. That's the Fuller stock take. And then Darzi talked about, we've got to do it closer to home, right next to the practice, in those communities. We've got to do innovation. And the question that I always chase is, have we really given the freedom to not just GPs and their staff, but also the wider community and our resident leaders? Have we really given them the kind of freedom to innovate to where we could do things slightly different? And it's all about reform. And what you're seeing is really, or my view and my experience is actually, there is something quite fundamental about reform. And guess what? Labour, the 10-year West Streetings, NHS plan talks about prevention again, and hospitals to community, and technology and AI. Next slide. So my journey started in 2023, where it was around Eid and Ramadan. And a group of local residents said, look, could you come and just talk about Ramadan, and about long-term conditions and what we should be eating and what could we do differently. I mean, it started from there, and then the journey was, and then I kind of thought, well, I don't have time to do this. I don't really, I can do something, but I'm not sure what I can do. So I went to our local community group, which is Thames Life, and they said, no, don't worry, we'll do the comms, we'll do the messaging, we'll get the message out to all the communities and speak to the residents to say, look, we're going to set this thing up and come and ask questions and so on. And then from the success of those integrated pop-ups, we realized that actually the model would be good. And I'll go through what, the kind of journey that I've been through. And then we started looking at homeless and children and SMI and diabetes. And then we started thinking about the diversity. I mean, North East London is a very proud, diverse population with diverse staff. And then we said, look, is the methodology the right method for our local population? We have a large Afro-Caribbean population who have very different needs, who have very different understandings, and have different views of what healthcare should be. And then we did, very targeted population groups from that. And then from that developed to saying, well, why can't we do something more proactive, like dealing with knife crime. I mean, GPs dealing with knife crimes, that's something we do. But actually, yeah, we do. We get like, we get some ideas of children who are getting involved in what they've been in incidents in the hospital, or they've been, their parents are worried about that they're going to get involved with gangs. And then we started thinking about, well, what could we do to give people different choices going forward? And we talk about the partnership bit later on. And then on that background, I said, well, actually, let's go even further. I've got a lot of patients who come in asking for medical certificates, and if they were supported, could we do a different way of looking where we can, support them, encourage them, and provide them a level of support where they can go back to work, but feeling, happy and, supported and doing things differently. And again, I'll talk about this. And this was all from those pop-up, the start of the pop-ups, where we kind of pushed and pushed and pushed and said, you know what, could we do something different? And it was our resident. It was a very co-created model, and it was a great experience for me. Let's next slide. So you can imagine when I first started this project, this was the advert. Free drop-in clinic, no local, see a local doctor, no appointment needed. I was horrified. I said, my God, that I'm gonna collapse under pressure. And then they said, look, no, 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 we're gonna provide some other stuff that will support you, and we'll, and it became a giant clinic with NELFT, with talking therapies, with health visitors, with, our local trust, with the housing team, with the community groups, and, the pharmacy groups, and, and it was all it was a fantastic. When I came into the program, as in I came into this building, yes, I was doing these kind of clinics, seeing a local doctor, and in the first clinic, 500 people turned up. And what was bizarre, and I thought, I'm going, this is crazy. What have I done? And a large proportion of them were my patients. And what was really surprising was around out of the 500 who signed up to say they needed to see a GP, myself and my nursing team and my colleagues, only 250 actually saw us. So exactly 50% who perceived they needed to see a GP was dealt with other services. And I thought, wow, that's fantastic. And we'd done this, and we tried different sites, and we moved around to kind of get through, and it was a see and treat, and a lot of people said, oh, how do you do the kind of, so what we did is using EMIS systems, we, if they weren't my patient, we temporarily registered, and we said, immediate necessary, so that the data can go back to their GP if there was anything that we needed asking the GP to see. So there was a data source going back to say that. So and I've got to be honest, we didn't get this all right at the beginning. It was after every clinic, we sat together with the community groups, with all the providers, and said, what did we think? What could we do better? So it was a very kind of moving model. And I really enjoyed that because people came up with solutions. Next slide. So you can imagine, so you can see the different groups. And I just wanted to tell you a little story of, and there's my team at the bottom slide. There's on the middle picture on the left, you see these fantastic group of individuals who were doing massages that the council said, oh, we'll do massage. So they used to deal with, anyone who would like a free massage, they'd give them 10, 15 minutes. Do you know how many safeguarding referrals we picked up because people opened up about what's going on in their home? And these were people we already knew but didn't know they existed. Safeguarding issues, critical crisis issues. We picked up so many issues, cancers that never got picked up before. We saw stage 4 cancers that we'd never seen, and yet they'd never come into the practice or in the hospitals to see anyone because it was there, it was in the community. We have a lot of children in our group, and there's a lot of young mums who didn't have the support in the network. They're the ones who kept on coming in for any kind of mild respiratory symptoms and things. And actually, we found that actually the community groups were great about teaching people to cook, or to look healthy, to feel healthier, to support them with all these different groups. And the real winners were the communities, you know, groups, the residents. They were the ones who really did it for the love. They don't get any financial income. Most of them are very, you know, they just did it because they love to help. Now, what was really bizarre in these clinics is one of the stories I had, we had a nurse, a staff nurse from BHRUT, who had been signed off sick for anxiety for 5 months. And she came to see me in this clinic, and I introduced. And one of the beautiful things about learning and the learning journey I had was I got to meet all the community groups, and therefore I was advocating the groups. So they come in my room and they said, "Oh, do you know what? I've got this, this, and this, and I don't have any support." And I said, "Look, just hold on. Let's go out." And we'd go over to one of these fantastic individuals and said, "Look, why don't you have a chat with them? And then next time I see you, we can talk about what you're doing." So I was getting involved. I was almost advocating these community groups, and they were willing because a GP had said it.
Mhm.
And this lady who came from the Indian subcontinent was very isolated, no family, and so on. She actually went back to work because she got involved with the different groups after 5 months. And this is us signing the certificates to say, look, can we get you some mental health support? She was sent talking therapy. She went, but she actually didn't need it. She just needed a network of people that she could be around because she felt very lonely. And she went back to work. Or there's a lady there roading rubbish. And what that group does, they go along the River Thames picking up rubbish. Really interesting case. One of my own patients I've known for the last 20 years who struggled with weight, and I've sent them to gyms and things and everything like that. And they just, and not really lost. She went to this community group and lost 15, 20 kilos for the last 5 to 6 months. This is after me trying 10, 15 because she had a group and group of people. I could go on. There's lots of great stories, and it really enriches the heart when you see, you know, that change in front of you. And one thing I did love, there was no forms, whether it be NELF, whether it be HRT, or whether it be thing. Everyone said, look, don't worry about the forms. We'll sort it out. We'll just take them on. And we were doing MDTs right in there and then. You know, we were saying, we've got a dentist in one of the clinics. We had dentists coming along. We were dentists were referring to mental health. Mental health were coming to me saying, "Look, we think she's got a physical problem," and we were just dealing with it then and there. And then they would carry on. That continuity would carry on. Next slide. And this is about the homeless. And the homeless was a really different thing because homeless don't trust you. They want to get their food. We based it around what happens with food. You know, they had their food. They want to get the food and leave. And then what we did is, well, where the charities were doing the food, we were doing haircuts, we were doing, you know, showers, we were giving health packs. And then we started dealing with their complex mental health, their alcohol and drug problems, and there's a charity from Camden who came along and said, you know, this is we do free showers and give towels, and they did that, and they brought this box, and you can see it in the background. And so then we ended up getting a one-stop shop, and then we started dealing with why are they homeless in the first place? You know, what could we do differently with the reason why they are homeless in general? And we had people for organisations never knew existed, you know, for refugees and so on, you know. And it was a fantastic experience because we started, it wasn't just about a homeless person getting a check. You know, they were having a, you know, and we created different models. While they're having a haircut, we'd have a chat and say, you know, what's going on in your life? And we got a lot more out of them than probably would have done in a normal GP setting if they came. Next slide. And just to give you an idea of the scale of things, we had the British Red Cross, we had social prescribers, we had the community groups, and we had people getting people back into work. And you can see the barbers there. They were just coming, and these are people they just come voluntarily because that's what people. What's what the residents said? Oh, I need barbers, or I need my medications, and I need you know somewhere to live, and I've got these issues, and so on and so on. And we carried on those journeys. Next slide. So we did something like we thought, okay, let's do something special, children's and families. We did a kind of very much a Christmas theme. So we had Santa there. We gave 700 little toys and gifts to the children. We fed almost 1,500 people. We had asthma nurses from BHRUT talking about asthma and, you know, trying to get, we had tiny tots and boxing and, you know, people getting stuff for where we can, and we thought, let's go even further. Why don't we have like a bit like an exhibition center? So we had lectures where children and adults could come and listen to, you know, how do you get fit, and STI training, and job market for children, you know, young adults, meaning, and then ADHD, things that people worry about. And we did general health topics and practical sessions. And so it was free haircuts, Santos Grottos, health support, and all the activities you see on that screen. And it was such fun because we were designing things what people wanted, and all our trusts and everyone was there, and we were managing to improve compliance of medications, and we were getting people involved, and health checks and health, and there were missing children. What was really strange is that we realized there were children in Barking Dagenham where this was done that hadn't eaten for a day. You know, imagine London being a capital city of the country, and yet we've got such real poverty going on. Next slide. And then we thought, okay, let's try and do something. And I talked about health and well-being in the Afro-Caribbean, and we wanted to do something different as well. And what was really interesting, we had the Cancer Alliance, and we, as well as having the, you know, the basic model of health checks and, you know, seeing patients and all the kind of groups that we had, you know, hot meals, and we designed our fantastic church, the Sources. There's a group of churches that created a meal that was Afro-Caribbean in the sense of, you know, what were the traditional dishes and things going forward. You know what the most important lecture was? What the people, we had the biggest numbers where we did the thing, was actually about how to deal with your hair. And Afro-Caribbean, that was the most important thing to them. So we had a lecture about hair, and then we can talk about prostate cancer and healthy heart and work health, and, you know, talking about that trauma-based kind of care, and, you know, we're talking about communities and people affected by this going forward. Next slide. So in overall, we've seen probably close to 11,000, maybe 12,000 people in our pop-up clinics. They're not all registered with local practice. We didn't care. It's whoever wanted to come. We didn't care who the partners were. And what was really thinking, it's like a change model. Once we got going, other people said, can we join in? Can we do something? Can we? We had Barts coming in and starting doing HIV testing from, you know, pop-ups, and hepatitis. We picked up in the homeless clinic hepatitis B and HIV that's never been diagnosed before. You know, and all these kind of things. And there was a real positive energy. And what was really important for me, learning from this, was that there was a real positive energy about general practice, that we are trying to do things differently, and we are trying to be supportive. And then the building of trust can create that can-do attitude locally. And of course, you still need primary care buildings. You still need that primary care support for any intimate examinations where you think it's not appropriate to do in the community. And I always had local buildings with primary care GPs who could, you know, stand by and say, look, I really need you to do something here going forward. Next slide. I told you about the 1,800 in the schools and the 600 children that we fed. But it was just amazing about the food and the cooking, the bops and the cultural activities, and the fact that you can really develop, you know, a kind of multidisciplinary. We had dental teams, we had mental health teams, we had a community pediatrician consultant coming from Delft who was giving lectures, and sexual health and asthma teams, and really getting, and this for me is the formation of that integrated teams. Next slide. I talked about the homeless and how we can move on, but, you know, one thing I did feedback is that the homeless would say, well, if I don't get what I need, I go to the A&E. There was no, I don't see a GP, I don't see, and I'm sure Mohit's had examples of where he's done work on the homeless. You know, you see this, there is a, you know, because of the nature of how they're trying to manage their lives, it's emergency care or nothing. And that was something quite impressive that we learned, that we could really help this group. Next slide. I talked about the Afro-Caribbean culture, and that you have to really get a co-created group. And we really did a kind of stakeholder approach where we went to the faith groups and said, look, what would you like in these clinics? What do you think would help? As well as seeing a GP, that's a given. You know, we know that you want to see a GP. But one thing we did do in this one was we had the BHRUT midwives who are fantastic because of the Ockenden report and about the, that Afro-Caribbean and minority groups have a very poor experience of birth and birthing and so on. And we wanted to really change that to say, look, let's ask those questions and get that experience and what could we do. And we had a consultants from hematology about sickle cell because that was a specific issue in this group. Next slide. And of course, we managed to pick up the press, which is always nice. But one thing I will say, it's nice to celebrate together. And it's not just for you or the team, it's for everyone that they feel they're doing something fantastic. And there's a lot of joy there. We're not being told to be happy. We were very happy about doing it. Next slide. I've told you about the knife crime, and the work on that is where we have West Ham United and different provider providing mentorship and support with these groups of young men and young adults who are considering and offering them different solutions. This is something I learned from other providers, and that we've had some really good success about getting people to have different options, because when the youth centres went, a lot of the options for young people left. Next slide. And then I've told you about the mental health. We're trying to look at, say, look, if someone comes in for stress and anxiety with coaching support and lifestyle support, could we offer? And we're doing this across the three. There's three, City in Hackney is a PCN in City in Hackney and Waltham Forest. And we're trying to see if we're in the DWP are very keen to see this work, because clearly it's something, if we do something, and that means the biggest thing is they have time with mentors to kind of deal with their stress and offer different solutions. Next slide. So I better close up because I know I'm going to get called by the chair. But co-production is key, and we're very fearful of this. And I got to say, it's such an enjoyable experience. My next clinic, if anyone wants to come, is on the 24th next week on the Barking Riverside, and we also have a maternity and neonatal clinic. I believe it's going to be on the 22nd of Feb. Again in Barking going forward. And if anyone asks, we used the whole of a library. So it was the local authority. And the local authority, the particular guy, Zonal, who was fantastic, who just supported all these programs, and getting local authority, and Lucy from Thames Life, I must give them credit. So we picked up serious health issues, cancer, mental health, safeguarding. We picked up acute needs, dealing with, stopping people from going to hospitals because they had no other choice. We did MDTs in contact, and actually, we talk about neighbourhood teams, but actually this is a very pragmatic approach of who is in your neighbourhood, what is your neighbourhood, and I've told you about the joy in the last slide, believe. Next slide. So collaboration benefits shouldn't be underestimated. It's interesting that around 400 calls were less on the Monday morning after I do a clinic on looking at my data of the people coming in. Primary care does need to lead, but with the community, it's got to be together, and allowing the staff. And it was the innovation what's really impressed. Staff health visitors, community nurses, BHRUT nurses, and consultants were just saying, "Why don't we do this next time?" And it was just amazing. Continuity. Everyone goes on about, well, what about the continuity of care and things? Well, continuity about what? If it's a housing issue, actually, it's the housing team that should be continuing. If it's a mental health, we can provide that continuity as a GP and supporting and making sure things get done. But it's in the need. I think it's a need-based approach going forward. And in some respects, we developed a single point access for all services at those clinics. It was a single point. And you do need to develop a governance framework. And I get told, we need to sort a governance framework and all partners, and we need a population health. And we do, because we pick up the issues and we develop that population going forward. And we are developing, one thing we are doing is having a director of services of all the stuff that we deal with and picked up going forward. Commissioning is always a problem, but for me, it's just say, get something done, prove your work, and then go for the commissioning bit if that, because obviously there is a huge amount. And the biggest benefit I've had is we've had so many kids who've asked to join for work experience, who are really keen to get into the NHS and social care. And that was something we never expected from local schools to say, look, I really want to be a new doctor, a new nurse. I want to be a social worker, I mean, or I want to be a health visitor. And we were like, wow, where did that come from? You know, what happened? Because they really enjoy this. And you know, we're getting a lot of interest on employment. And one thing we've gained from this as a practice is that we're getting a lot of people coming and asking to join the practice. And the last thing I would say is comms, 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 celebrate. We've put ourselves for awards, we've got awards, we've because of the work, we're funding for pilots, and there is something about making sure everyone knows about it because the developing going forward. And the one biggest thing is the community just don't have funding, and it's also supporting them to have funding, you know, those community groups. Next slide. So that's it. So really it was about our model was really about this is what I really want. This is what I need to work in my practice. And it's interesting, you know, Gandhiji, as we would call, would said, well, do it and try and see it. So thank you very much, Mohit. Over to you.
Jagan, I'm just awestruck. It is such a fabulous story of change and change from so many perspectives. You know what really drove this true to the community's heart is makes a difference to people who are being served there and then, makes a difference to the people who are serving them there and then, but also makes a difference for the generations to come in terms of the experience and things like knife crime and picking up issues that would not have come out. Because safeguarding, I know it's a health term, but actually, safeguarding has such much wider connotations for communities in terms of the impact it has, whether it be financial, it may be personal safety, it may be how you feel as an individual and your self-worth. So it is just such a telling story, and I'm so glad you're here today to share this with us. I think, as you can imagine, there are tons and tons of questions that have been pouring up on some on the Q&A, some that have been sent to me in advance. Some people have been getting across to me on places where they should not have access to my emails, but they have managed that too. So, but given I am hosting the series, so I get the choice of picking up the first one, and I'm going to pick up the very first one, which was phenomenal in terms of the work you have done. What was your biggest challenge in getting this to happen?
Well, that's a question. Part of it was personal, my perception of what this might be. When I've reflected on this actually, personally, to think, well, actually, my perception was fear. I mean, I was fearful to think this is going to be a super duper horrible day at the GP practice. That was my personal perception. And until I tried it and actually realized, yes, it's hard work because obviously you are seeing people and things, but you end up realizing that you've got help. You're not a single person in a room. You are a person that has all the connections in the world to do something different. And my question is where is there, and it's a really horrible thing to say, but I used to always believe that people always knew what they want, including me. And actually, I realized the public don't always know what they want. They know they need something, but sometimes it's down to experts to kind of guide them through that journey in terms of things. So my first one was my own resistance. The second thing was actually people were saying you're just doing something that's just not doable, or it's not. And to an extent, they're probably right. There are so many reasons why we can't do this because we've got pressures and things like this.
Yeah,
But
yeah.
my view, I've always said this: unless we do something radical, we're not going to be able to sustain the NHS in the way that we are now. We've got to do something. If we really want to get to prevention, how can we be doing prevention if we're always just doing reactive care? You know.
Absolutely. And I think what's fascinating in what you said, Jagan, is there is no size in the scale. So if you think you can do 20, do 20. If you think you can do 500, do 500. But you started somewhere and look where it's gone today. So less worry around how big I can do, more worry around I want to do it. So let's just get started and do something.
Well, we did. I mean, we did a borough-based we did a borough where all PCNs joined together, and we saw 7,000 people in 5 hours.
Wow.
And
Isn't
so
that a
we
number?
did a giant thing. We just went scale. I'm not sure I'd recommend that because that was
Well,
quite. We had people roaming the road. We hired it, or the council had managed to take out a massive gym, and we had all sorts of different activities and things. So we've tried at scale. But if you really want to get neighbourhood where you get the nitty gritty and you really start dealing with the issues, I personally feel the neighbourhood approach is probably the best bet. But yeah, but you
and
can scale.
and there's a question about, so when you are a success story, it's easier to engage people. How do you get people for the first one? How do you get the first event with stakeholders involved in it? And someone's put this question probably a lot more eloquently than I put it to you, but where do you get that seed and how do you get others engaged in, making them feel that they own it?
So for me, I would like to take credit, but I'm not going to. It's the community groups. They were the massive caveat, and having all those community groups and the local, the health visitors. When I said, "Look, do you mind coming for this clinic?" Said, "Yeah, we don't mind. We'll give it a go." They didn't know what to expect. So there's the kind of fast learners, the cavaliers, the people who are just go headstrong into a kind of problem, and they say, "Look, I'll just do it." But then you get the people who we said, "Can you come?" And they came to see what we were doing. And they said, "Do you know what?" And I can never, there's nothing in this presentation that could really give you an idea of what it feels like and how it is unless you go and do it. I've asked people to come, and that's what's driven people. So it's a two-pronged approach, and I'm saying, look, use me. If you want to do something in your area, or you feel that you've got the skill sets and you've got the connections, come and say, look, why don't we go and see what they're doing? And that's what a lot of our Waltham Forest colleagues did. They came and then they said, oh, we like this, we're going to do this something. So you do have two types, and that's like general practice, isn't it? You get the people who are willing to do something very maverick, and then there are people who are got to be careful and do it in a measured approach and like to test and then do it. So, and I think both approaches are okay.
And so Jagan, how do you synchronize this? Because when you're working at that scale, there's likelihood of some duplication, people doing stuff that someone else is already doing, and it's such a large scale you're managing. How did you, what was the framework that you used to try and synchronize it so that you could get the biggest impact and the best impact?
So there was a lot of organizational things. So there was something about learning who the people are and what they do. Really learning. And then the question I always ask my GPs and my colleagues in my own practice, say, do you really know what these people do? From health visitors to, that's, statutory service, or even the consultants in the hospital. Do you really know what they actually do day to day? All those community groups, Tiny Tots, which is a group where a dad decided he's going to start a nursery group where they little children sing. That's what he does every week. And it's really popular in my area. They love them. Everyone drops their kids because the kids love it. Now, do I really know? But understanding that they're actually taking them out of their environment, which may be very hard, maybe poor, but they've got something different. They're outside of the environment they live in, that kind of poverty area, and they're doing something different. So what I was trying to say is that you have to do a bit of research and understand the people you do and what they do. And then once you've got the kind of the not only the knowledge but the confidence that what they're doing and providing is good, and then you develop that trust and that kind of element. So that way you then can say, right, and it becomes easy to manage because then you suddenly said, well, you don't need me, stop there. Let's go to that group because I honestly believe this is the thing. And if I'm wrong, dear resident, if I'm wrong, come back to me and I'll give you medications but do you really want that? That kind of thing. And then they say, okay, I'll give it a go because you told me to. And then suddenly, I was really upset initially. I had this kind of paternalistic say, where are my patients? I don't see them anymore because they don't need me. They've got other friends. They got, those people who just book an appointment. I don't know how they book an appointment just to indirectly just have a chat, and they actually got
Absolutely.
other people. So there is something about, thinking of the model and using the assets that we already have, truly use the assets going forward, and therefore you can manage demand in a slightly better way. And I always ask to my hospital colleagues, where does the front door of the hospital truly, where is it truly? Well, it's actually in the community,
Mm.
because there are always escalation points where if you don't intervene, or you don't get it recognized, they end up in hospital in some way or form.
And clearly, from what you're expressing now, this awakening of an understanding of the role, and there's a question about this too, goes well beyond then the pop-up clinics, isn't it? Because then the relationships that form and understanding that form changes the way you practice going ahead as a clinician, both for the doctors and the nurses and the therapists and the pharmacists and even the community groups, because they know each other. How did you find that change then make a difference?
I think you're right, because I was aware of things, even in my clinical practice, I could refer and use them, and not just in the pop-ups. And obviously, you're a lot more knowledgeable of the local system. But then there's also something about the well-being of your own staff, because you're now supporting your own staff, your receptionists, to say, you know what, there's something in the community that could really help you. You're not just thinking of your patients, you're also thinking about your staff. You're thinking about, there's some really I mean, I won't tell you, but there's so many different fantastic groups that if you really want to talk about well-being, go and do some art therapy, for a week, and as an employer, we'll do this locally. So it has changed my way of working, because now I'm thinking, pain medication and LTC rehab, respiratory rehab, breathing exercises, when you're literally saying, go to that community group and walk up and down, and you start to meet people and things like this. There are other things, whether it be the depression or whether it be the heart failure, or indirectly you're doing nice accredited, indirectly you've got no proof for it, but you've got a nice accredited pulmonary rehab, or you've got you're doing things slightly differently. And the biggest thing for me that has changed the way we work is now we're empowering people to actually take responsibility for their health, rather than saying access, 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 access. It's not access. It's actually about you taking some responsibility. We all have to take responsibility. But if you tell that to someone, they don't like it. If you give them the means to start empowering themselves, they'll start thinking about, well, what am I doing for myself? What am I kind of thing? Do I really need to see the GP? When, what is his options, that kind of thing going forward. And then you get to start really thinking about we start to see the acuity that we do, the real medical needs, the complex frailty or the complex long-term conditions and things like this. Those are the kind of things we really need to see. And it indirectly becomes like a community triage.
Yeah, yeah. And I think, as you can imagine, there's always going to be this inevitable question. How did you get the money to do the job? And it becomes the more important talking point than the relationships that make it happen in the first place in the communities. And so, from your experience, because now you are then in addition to all the wonderful roles you've done, which I recounted, and I'm not going to bother do it because I think I will develop distress, respiratory distress, trying to do that. But now you're also the national guru on creating these health camps. So what was your experience, and what do you think would have helped drive? Did that money and resource matter as much as the relationships and build? And what was the kind versus actual resource balance in getting it off the ground?
So we didn't get paid. I didn't get paid for anything, any of these things. That I just want to make that clear, because that's the first question colleagues will say, "Oh, did you get paid?" No, I did something that I thought might help my own practice deal with access and demand. Could I put it as a CQC thing? Look what I've done differently, or could I say to? But it was really to say, how can we manage the demand that's coming into my practice on a daily basis? Because the first ones were just in the next building opposite. They were just literally next door in the community hub. The community providers were paid through the local council through existing funding, and they also were very clever. They went to the local builders and said, pay for our thing so that we can support. Because one of the biggest issues, as you know, with any survey is health. You know, where is the health? Where is the that kind of thingy? And then the other thing that was really strange, I didn't realise, Mohit, was actually there is a lot of providers being paid for outreach work. So Bart said, "Oh, actually, we do have funding for doing this work for outreach, whether it be sexual health or, even now, they do lots of work with things like inequalities. And we used some of because I'm a health inequality lead, there is some small amount from coming through the PCN for health inequality through the health inequalities funding and so on. Clearly, that isn't provide all the team that I support or anything like that. But the idea is, Mohit, is to really talk about kind of changing the model and demonstrating to colleagues, whether it be ICB, NHS, Wes Streeting, whoever, to say the model has to change. And there is a flaw in all of our contracts where it doesn't really allow for collaboration. It's a bit more, it's a nice thing to do rather than things you should do. And MDTs, of course, are somewhere in the middle of all of that, where there is some resource for some things like MDTs and things. But how does a GP go one stage further? And for me, I hope that I can hear lots of things where people have done something so radical, and I'll come over there and say, look, I want to learn from you because we want to do something different going forward. So funding was never the driver for me. It was really the driver was to prove that as clinicians, as leaders, that we can do innovation in a slightly different way. And gloves off, I'm going to get stuck in. We don't know where it will go, but hey, we'll give it a try going forward. And one thing I realize is that actually it's not just me. There are some incredible GPs and nurses and all social prescribers and all different who've just got amazing ideas, but they just haven't had the forum to do it.
I think it's fascinating. I mean, never has the idiom where there's a will, there's a way been more aptly demonstrated because, I mean, for instance, this particular webinar series for the last 3 years that I've been hosting, there's no funding for it. There's nothing that I've had. I've been in different roles and it's not something that's part of the role, but you believe in it. You really think sharing good practice will make a difference. And I've seen repeatedly people then come back to me to say, oh, you said about that, we have done this now. And you sit back happy because you think 10,000 more patients have got better care because you put in the effort to share that out. And it's very similar to what you're talking about. And it's really good to hear that because it's quite interesting how good ideas die out because people think funding is the most important part to start with, was actually just leveraging what exists in the system and making a large scale impact by breaking those boundaries gives a much better outcome to what you can deliver. And it's fascinating, isn't it? Without the funding, but you've managed to demonstrate that Mondays you don't have the same footfall on your outpatient just because many of them have had the many people have been picked up much earlier. Those safeguarding concerns that were not on your EMIS are now on the EMIS very simply because they have come out through a massage session elsewhere. But that particular patient and family ends up getting better care. What can be better in life than that? And I think it's fascinating. I think we are pretty much coming to the end of this, but a very quick word on there will always be colleagues who will be worried about what will the CQC say if there's an incident there? What will my insurance say? What will my indemnity be like? Any views on that? Did that ever come in the way of your ability to make this change?
No, absolutely. Indemnity was the thing that was probably, I'm still a jobbing GP and we go down a certain template, don't we? But what I was really surprised about is when I went to the National Indemnity Scheme, they said, yeah, no, you're covered. I was like, really? But we're not even in our building. We're not, where's the infection control? Where's the
Yeah, I
MRSA?
know.
And where's the sort of, and it said, no, yeah, no, you're covered as long as you work collectively and you take safe, thing and, you don't obviously put anyone at risk and things like this. And of course, you will get the emergencies that will need an ambulance. You will get cases that require you to pick up even later after the event and things like this. And you build a process of doing it. But it's truly fascinating. Like, another example is, the indemnity and all these things were never got in the way, actually, funny enough. And so far, touch wood, we haven't had any incidents so far because we're all dealing with it collectively together, and and mitigating the risk as much as we can.
I mean, if I stuck to the questions on the Q&A and the other questions that have come through, I could probably be all night here, Jagan, but the commitment to all our listeners is we will stop at 8. So I would like to start wrapping this up. I mean, 30 years ago, I remember as part of becoming, and this is slightly more than 30 years. I mean, I try to keep reducing, making sure I look younger in age. You make it 30 and not 34 so that it makes me feel better. But as part of becoming a doctor, we had to do a large community scale project, and I led an immunization camp in India. And this is ages ago. And I remember with 10 nurses and myself, we had immunized almost 350 people. So from different villages, they had come and we'd created this camp. But I have not seen that replicated in the health service. And primary care is so much more than provision of just medicines and diabetes and hypertension and cardiac management, because this is prevention is the bedrock of what primary care is all about. And I think your leadership in inculcating those ethos of prevention within the model of providing large scale health has revolutionized access to so many people. And many people, I mean, I would not even read the number of comments I have on the Q&A around saying how wonderful this is, how much they'd like to see it. Someone who I consider very dear to my heart, Jamu from Luton, has said, "Oh, we'd like to do this in Luton big scale." And Keith has asked questions and people are just completely taken in by this amazing work you've done. And there are some things that have struck a chord with me today. I mean, what I really liked was how simplistically the idea started from your personal experience of saying, can I make a difference? No boundaries, no airs about it. Just, I've had this experience and how do I make this change? What I really loved was the use of the word proactive. It was proactive. It was not around what can we do to support people. It's more about how do we get them to have ownership of making things different, and let's help them get in that space. Startling, really startling, the fact that 50% of people who turned up didn't even have to see a GP. Isn't that amazing? It's exactly the story of why primary care is so besieged by people wanting to access it, because there are so many things you get access to, but actually it stops the people who should have direct access to GPs just because we don't have a system. So by creating this system, you have created something really different and created a solution. And the scale of engagement from partners, breaking those traditional boundaries with the local authority colleagues, with the acute trust, with the mental health trust, with the community services, voluntary sector, name them, is probably one of those enthralling moments which you hear and think, wow, that makes primary care stand out. So hats off to what you've done, Jagan. Absolute hats off. And thank you so much for sharing some significant insights into making such a difference into the communities that we serve. Now, colleagues, no webinar can be successful without the active participation I have had from you all. You all are just amazing. I mean, the mere fact that 350 people have registered for today's webinars. I mean, we have colleagues from Canada and Australia, if I have read the email addresses correctly, who are logged in to hear this wonderful thing. So please remember, you heard it here first. Patent it for what we have been doing in the NHS and making a difference. I think it is absolutely phenomenal. Thank you for your active participation and making me feel that it matters by so many of you joining. But please do use the QR code that is on the screen, which some of my phenomenal colleagues in the background have put up really quickly, and give your feedback, because your feedback is very vital and helps us change. There's one question in the Q&A around AI. Colleagues, please hold fire. We will have a session in April with a colleague, with one of the AI rollout colleagues who is an absolute leader in what they have done with the use of AI. It's because we've been planning for the next 6 months. So please hold on to that question. It'll come back. Also, a very, very big thank you to the amazing colleagues in the background, Sam, Holly, You are, hats off to you for keeping this going and making it look so smooth in the background, because without you, I couldn't have done this, and nor could Jagan. Wishing everyone a great evening, and thank you for joining us. Have a great one. Bye bye.